I'm Laura Forer, as you can see on my window here. I'm a volunteer with the New York chapter of New York Metro chapter of the Star Legacy Foundation. And I think most people are familiar with Star Legacy. For those who aren't, they are a nonprofit. Their mission is to increase awareness, support research, promote education, and encourage advocacy and family support regarding stillbirth, pregnancy loss, and neonatal death. I know for me, they were a huge support after my daughter died, and I think for many of you as well. My daughter Naomi died at 38 weeks in 2018. She had a true knot in her umbilical cord. Star Legacy got me in touch with Dr. Jason Collins, who's here tonight, and he helped me navigate this new terrain that many of us are in, and the questions that come up with it, such as how did this happen? Why wasn't such an obvious thing caught? And how can I make sure this doesn't happen again? I know that I'm not the only one with those questions. Dr. Collins has helped many of us who are on tonight. And I'm so excited to have him here now. I'm so excited about it. So I feel like I'm in the presence of celebrity. Dr. Collins specializes in obstetrics and gynecology. He has a master's in clinical research from Tulane Medical Center as well. He spent his career studying the role played by umbilical cord in stillbirths. He's the principal investigator for the Perinatal Umbilical Cord Project, which is a study that reviewed over 1,000 no-risk pregnancies for umbilical cord accidents. And many of us have read his book, Silent Risk: Issues About the Human Umbilical Cord. Dr. Collins joins us from his home in New Orleans. I think, are you in New Orleans?
Baton Rouge. I'm from New Orleans.
Oh, Baton Rouge. All right. In Baton Rouge tonight. I know that I'm not the only person excited because we had over 50 questions submitted for tonight. So we will not get to all of them, unfortunately. I've tried to consolidate them, and we'll just do our best to cover what we can. So without further ado, Dr. Collins, many of the questions that we received asked about how to monitor for cord accidents in subsequent pregnancies. So let's break that down into a few aspects of prenatal care. So the first question I have is, what should we be asking our doctors to monitor for the cord?
Well, the foundation would be at your 18-20-week scan, which is for congenital anomalies. That was the purpose of that scan. A lot of people are under the impression that during the 20-week scan, they're looking at umbilical cord anatomy, which they really aren't. They're not obligated or required to do so. So the American Institute of Ultrasound and Medicine does have a recommendation that, they'd like to see a 3-vessel cord and they'd like to see the cord insertion. But very few people follow that recommendation. But what should be happening is at that 20-week scan, they should be looking at the umbilical cord in its entirety, from the placenta and insertion all the way to the baby and the insertion, because you can have pathologies at either end or all throughout the cord. And I was telling Laura earlier, there's over 20 pathologies, and combined, that accounts for 19% of stillbirths, period. So when you look at high blood pressure, that's only 8% of stillbirths. So umbilical cord pathology by far is a very important factor in stillbirth. And the question is, why isn't the professional organizations including it in their continuing medical education? You can't find a single lecture on the topic, whether you're looking at an OB meeting or an ultrasound meeting. And I constantly write these people emails and say, are you going to present this topic anywhere? And if so, who would you like to deal with it? Like someone like Tim or Trish, who Laura's familiar with, who's very good at ultrasound in New York, or somebody who's very good at pathology. There are a number of these people like Dr. Redline, who are excellent placental pathologists and can give a good review of the topic. So you got to start at the very beginning, and then as you go from there, anything that would bother you relative to how the baby's behaving, anybody complaining of a change in fetal behavior, and notice I'm not using just the words decreased movement, I'm talking on behavior as a whole. If you feel like, well, your baby's not doing what you're used to, which this lady noticed at 24 weeks, who's out in Arizona that I've been talking to for the last couple of weeks, that her baby just basically stopped moving, and they wouldn't do the ultrasound because they didn't see the need for it. But we finally found an expert out that way, Dr. Elliott, who's excellent. He usually manages triplets and quadruplets, who did the ultrasound for her and put her at ease that there was nothing obviously wrong. So you're going to hear some people say, oh, well, the baby's too early. What do you do if we find something? All that's illegitimate. You have to define the problem, and the only way you can define it is you got to look at it, and you got to look at it in its entirety. So anybody that's had a loss to an umbilical cord pathology on a subsequent pregnancy needs a complete review of the cord at 20 weeks. And if there's anything there that looks out of sorts, then they need to repeat those ultrasounds every other week.
I want to clarify, you said it's starting at 20 weeks. Yeah. I know when we've talked before, I think you said, or maybe I even contacted you after I was at my 20-week mark, but you kind of said later. I just want to make sure people know that it's never too late to go. If you're at 29 weeks, 30 weeks, right, still go.
Yeah, it's never too late to go. And what Laura and I were talking about is that I've used boutique ultrasound clinics to do the same thing when the doctors have refused, and just have the patient send me the pictures and I look at them for. And that has been productive. We have found problems in those sessions. So you don't have to go to a hospital. You don't have to go to a maternal fetal medicine office to get an ultrasound of your baby. These clinics are all over the place. And if you're near a major city, you can find one.
I wanted one more note of housekeeping that I forgot. If you do have any technical issues, just message Star Legacy Foundation. They're hosting tonight. Thank you very much. Also, this is being recorded. We will post it later. And also, if you have any questions just that come up during this, put them in the chat, either to me privately or to the group. I will try to keep an eye on chat while we talk as well. Okay, so what you were just saying, you can go to the boutique ultrasound places. So ideally, of course, we would want our doctors to be looking at this. Many providers will not do it, but some actually just don't know how to do it too. What resources would you direct an MFM to that claims that they cannot see the full cord?
Well, what I've been doing is sending papers to those patients, and I sent those 3 papers to Laura earlier today so that she can share them with you. And those 3 papers outline all the issues you should be able to see with ultrasound, so that they understand they're coming from published sources. So there's no doubt about it that these things can be done.
Right. In addition to looking at the cord, what else do you recommend monitoring as far as a schedule for NSTs or BPPs, things like that?
Well, ideally, once you reach around 26, 28 weeks, the non-stress tests can be done twice a week. That's an old standard, but you can do that. And the value of doing it at 26, 28 weeks is that you can see what the basic, again, foundation is. What does the baby look like? So that if it changes down the road at 32 weeks, you can make a comparison and say, well, this doesn't look right. This doesn't look like it used to. I'm seeing these changes. We need to go and take another look with ultrasound and try to understand where the changes are coming from.
And we had a question come up in the chat. Is there anything we can do prior to 20 weeks?
Well, if you've had a previous loss early, like babies with torsion usually are lost at around 18 weeks, then you want to get an early ultrasound, maybe starting at 14, 16 weeks, where you can look at the cord to make sure that that's not recurring, which it tends to do. That not very many OBs understand these issues repeat themselves, but they do. So, curiously enough, my niece lost her baby to torsion at 24 weeks about a month ago, but they weren't aware of it, and they weren't aware of it on ultrasound. So depending on what has happened before, would suggest that you try to look for those things starting at around 16 to 18 weeks. Because basically there's not much you can do to a baby that's less than 26 weeks. Right now, the outer limit of survivability is around 24 weeks. But you have to understand, those babies get roughed up in the nursery because they tend to have other issues. So you want to try to get to 26 weeks if you can, 28 weeks even better, you know, because there are less complications with these NICU babies.
Yeah. I'm so sorry for your family's loss. That's always devastating. You know, one reason I think that providers won't do it early is they say, well, the baby is not viable before 24 weeks or whatnot. After that, they often say they don't need to look because there's no protocol for what to do if something is found.
Well, the protocol is simple. If you find something, put the patient on labor and delivery on continuous monitoring and watch the baby. You know, even if he's starting to get into trouble, you still can do a few little things to maybe give the baby a boost. You can give them steroids, prepare their lungs, and by being at bed rest, that might give them a chance to get out of the problem. But I mean, there are other kinds of problems, like you can have an umbilical cord bleed, what they call a hematoma. There's not much you can do about that, but as long as the baby is not having decelerations of a significant nature, you can continue to watch that baby, and they have a way of getting out of their problems when they can if you give them a chance. So that's the solution. Put them in the hospital, put them on a monitor, and just let them be evaluated on a constant basis.
Is that realistic to even at, say, 32-ish weeks or so, to say you just want to be at the hospital for the rest of, you know, for a few weeks?
Well, if the baby's not moving and you see entanglement, then you keep the baby as long as you can, because the goal is to get the baby as matured as possible. So yeah, I've done it for 2 months at a time, where I've kept people on a monitor in the hospital because their babies were having decels. And I just waited till it was so obviously terrible that I had to deliver the baby. But the idea was to let the brain mature and just let the liver mature, et cetera, in the lungs. And yes, I've done that. And I think that's what you got to do. You just push it as far as you can push it.
And what would the protocol be if the baby is fine or seems fine, but the cord has a knot or nuchal cords or something like that going on?
Well, like I said, you just keep watching the baby on the monitor, and you know, as long as he's not having decels, then you're fine. But you know, if they start having decels, then you're going to have to make a decision.
Okay, so potentially, if something is seen in a cord scan, you could always say to your doctor that you want to come in for more frequent scans just to watch for any decels or
yes,
movement.
And the other thing that we do is we monitor people at home. And what I need to do with you, Laura, is send you that literature if I haven't done it already. So, you know, if it's too inconvenient to go back and forth to a hospital that's an hour away, we monitor people at home and we check their heartbeats every night. You know, we've done quite a few of those.
Yeah, I think you did send me paperwork a while back. And is that a widespread? Is that something that any parent can access?
Yeah, the company is out of Houston. It's called Sense4Baby. It's an FDA approved monitor for home monitoring. So I think right now it's the only one on the market that's FDA approved for that purpose.
Okay, and that's Sense4Baby,
Yes.
As I recall. Let's see, we have a couple of questions that came in. Oh, can you define torsion?
Torsion is twisting. So along the long axis of the cord, it's a 360-degree turn against the long axis of the cord. So, you know, just imagine having a rope in your hands and you just start twisting it at one end.
Okay. So if that's essentially overly or under twisted.
Right. There's a verbiage that is being used today, which I don't agree with, called hypercoiling. The appropriate word is torsion, and it's been used since the 1600s. But a paper was written using this word hypercoiling. A coil is a wrap around the neck in traditional obstetrics. So that causes a confusion of the issue, unfortunately.
Okay.
But torsion is twisting of the cord. In
Okay.
other words, mechanically applying torque.
Makes sense. Thank you. So this question, we were just talking about protocol for what to do. And even though you kind of addressed this, I'm going to ask this question because I think as parents, we hear this a lot. And the question is, I've heard often there's no protocol for a nuchal cord. Do you agree? And I will say, like, if we had seen a nuchal cord when I went in for this full cord scan, I am positive my doctor would have changed nothing about my care, no matter how much I insisted.
Everything in medicine doesn't have a protocol. So sometimes it's just a matter of common sense. So if you have a baby with a nuchal cord and you can see it's indenting the neck, which you can see with ultrasound, well, then you need to watch that baby frequently. You want to look at that baby every week with ultrasound, and you want to be testing that baby 2 or 3 times a week with a non-stress test. So there doesn't have to be an algorithm or a printed protocol to know what to do about things like this. Just use your head.
That's going to be our quote of the night. Just common sense, people.
Yeah,
if you take anything away to your doctor.
Yeah, well, for the doctors to say there's no protocol to follow, well, really, it's just not that complicated. What you're looking for is a baby having problems, and he's going to show you those problems with movement and heart rate. So you want to check on that frequently. What their concern is that they think these things happen all of a sudden, and that they're going to be blamed for that. And my answer is no, it actually doesn't. Most of the time it happens very gradually over days, not all of a sudden.
I know that one mom on the call tonight is seeing Dr. Timur next week for a full cord scan, who is the doctor that I saw in New York. What are some questions that parents should be asking when they do go for a full cord scan?
So you want them to look at the cord as it's going into the baby's belly, because that's where pathology can happen. And they want to look at the whole length of the cord. They want to characterize it. Is it thin? Is it thick? What does it look like on the placental end? And that's basically what they need to do. They need to look at it in detail.
Right. Let's see, I'm going through our questions here. This is great. I'm so glad we have so many questions coming in. If we have an ultrasound at 20 weeks and placenta and cord look fine, when would you recommend the next one?
Well, you might want to take another look at 30 to 32 weeks. But as long as everything's okay, then you don't have to do that. But if you're going to do it again, that would be the time to do it.
Okay. Is there a particular time when cords tend to knot or twist or?
Well, in the case of torsion, Dr. Bernersky, who was a Harvard pathologist, actually looked at that, and he found that most of them cause death between 18 and 20 weeks. So actually, it's very common in horses and horse foals. They lose a lot of them to torsion. So yeah, there is a timing to it. As far as knots go, a knot begins as a cord around the neck. There's 2 types of cords around the neck. There's a wrap type and there's a hitch type. And if you get a hitch over your head, that loop works its way down the body like a hula hoop, and it comes off your feet and forms a knot. So that takes time. So when you're looking at cords around the neck, you want to look at the pattern of it, and you can see if it's a hitch type nuchal cord, and you can see if it's around the chest or the waist or the legs or the foot. You can see those things on ultrasound. So you can anticipate true knots by knowing how they form. Plus, you can see a true knot on ultrasound, and we're the first ones to do it and publish it. So it can be done. Now you got people publishing papers showing it in 3D ultrasound, which is really neat to see. So it's been done by a bunch of people now. It's out there. You just have to look.
Let's see, aside from decelerations, what should we know about increased heart rate or any change in variability that might signify the baby is in distress?
Well, the main thing is decelerations. You're looking for the heartbeat to dip down And the classic warning sign is a decrease in heart rate that goes down to 90 beats per minute for 60 seconds. It's a big U. Just think of a U shape. And if you see a big U shape, then you need to be evaluated with ultrasound, because babies do not decelerate. Babies will adapt with accelerations, not decelerations. So if you see decelerations, that means something isn't quite right and it needs to be looked at.
On that same vein, I'm going to ask another question that came in earlier, which is about hiccups. Can you talk about hiccups?
Yeah, hiccups is really interesting. There's a history to it. I was looking at a paper today where some of the original observers were in the 1700s, but they didn't have ultrasound, so they didn't know what it was. But basically, there's two types of hiccups. There's a physiological hiccup, which midwives and doctors refer to as suggesting the baby's healthy. They're developmental hiccups. They're strengthening the diaphragm. Those last 2 or 3 minutes, and they don't repeat themselves all day long. And people have actually looked at this. There are several papers where you had people look at the baby for 24 hours with ultrasound and actually quantitated the hiccup episodes. And there was a study out of Toronto and there was one out of England that suggested that average. So the average is these hiccups aren't more than 3 or 4 episodes in 24 hours, and they don't last more than 2 or 3 minutes. But then there's the pathologic hiccup, which I believe is a fetal reflex, like blinking your eye, trying to get dust out of your eye. And when the baby compresses its blood flow, it triggers this response. And people have actually looked at those hiccups with ultrasound, and there's some interesting components to it. But the bottom line is, if you have core compression hiccups, they're going to last longer than 5 minutes, and they're usually going to come around more than 4 times in 24 hours. So if you have a mom saying, I've had 5 hiccup episodes today while she's awake, well, then you can imagine it's much more than that, because she doesn't know how many she's having when she's sleeping. So that's a rough rule of thumb we derived from these papers. The one out of Toronto was John Patrick, and his fellow, Dr. O'Brien, who's no longer in practice in Toronto. I went to Toronto and asked him, did any of the babies have cord entanglement when they delivered when you did the study? And he said he didn't know. I asked him if they still had the records, and he said no, he didn't. So it could be that the averages they were looking at may have been contributed to by cord entangled babies, but they didn't know, so it figured into their numbers. So I use his numbers as a baseline. So again, what you're looking for are hiccups that are lasting longer than 5 minutes, and they're occurring more than 4 times in a 24-hour period. So we actually had that happen not too long ago, and we found cord entanglement in a mom who was complaining of constant hiccups. But yeah, the immediate response is, oh, that's normal. Well, to a degree it's normal, but after a certain point it's not normal.
Right. I'm just going to do a little plug here. So what I think a lot of us found after stillbirth is that there's not a ton of research, and Dr. Collins just quoted a hiccup study that he read recently. But if you'd like to contribute to research, Star Legacy has the pregnancyresearchproject.org. It's a survey about your pregnancy experience. And then what's really helpful is, after you answer all the questions, if you do give permission to release your medical records as well, they are anonymized. And then it can really help kind of understand patterns of, that we see in stillbirth and any kind of loss. So I encourage you all to do that if you haven't yet. Okay, let's see. Let's talk about something you mentioned earlier is recurrence. That's obviously a huge fear of parents. Will this happen again? Can you talk about genetics, or what are we more likely to have cord accidents once we've had one?
Well, it looks so far that recurrence is about 5 times. We actually looked at it with cord accidents. So it makes sense when you look at people who have had multiple miscarriages. There's something there that is leading to that result. And, you know, overall, out of NIH, Dr. Reddy studied recurrences and found it to be 5 times. But we specifically looked at 100 moms with cord accidents and had an NIH statistician look at the numbers when we completed that review, and it was a 5 times risk compared to normal. So yeah, if you have a cord issue like entanglement, et cetera, yeah, there is a recurrence rate. And so what that implies is something may not be developing correctly with your placenta, something may not be quite right about uterine blood flow. There was a question on there about oxygenation of the baby. Well, right now, there are a couple of papers that are looking at placental oxygenation with MRI scans. And so eventually they'll have a way of doing that where they'll stick you in an MRI study and they'll be able to tell if your placenta has enough oxygenation or not. So those things are coming. They'll be available in the near future where you'll be able to figure those things. But there is a genetic predisposition to cord entanglement, especially if you have long cords. And several people have looked at that. And so some of these issues are genetically driven, is what I'm trying to say.
Again, something there's not a ton of studies on, so please contribute to the research.
Right.
And when we're talking about long cords, quick question, 2 parts. First of all, can you tell the length of a cord in an ultrasound? And second of all, what do you define as, or what is the definition of short and long? Because I think among our healthcare providers, we are not getting consistent answers.
No, those numbers are known. People have done those studies, and the averages are known. A short cord is basically less than 32 centimeters, and a long cord is greater than 75 centimeters. So that is known. And I posted on Twitter the other day an image of a fetus with a short cord. And here's a very simple way of doing it, which I learned from a professor of ultrasound. If you look at the picture of the baby, like at 12 weeks and on, if you don't see umbilical cord, then it's most likely short. But if you see spaghetti, well, then it's most likely long. So you don't have to measure it to get a sense of whether it's short or long. Can you measure it? Yeah, you can. And we published that ourselves, that you can measure long cords. You remember Etch-a-Sketch? Well, these ultrasounds sort of have a caliper Etch-a-Sketch tool, and you can just draw it, whether it's curly or not, and get a cord length.
Let's see, I'm looking again at the questions that came in. I think a lot of people after a loss, especially a loss that is an unknown reason, or maybe might have been a cord accident, we don't know, the doctors say, just take some aspirin, it's not gonna hurt. Does taking aspirin, would that help with cord issues?
Well, the aspirin concept came about because of preeclamptics, because they tend to have microthromboses in the tissue. So they started giving them aspirin to reduce that tendency. And if you give it by 16 weeks, it does tend to help lower the risk of hypertension and these thrombi in the placental vessels. So it's not a harmful idea. It probably helps to a degree if that's the origin of the blood flow disturbance. So, but there's no direct use of aspirin in a study looking for cord accidents. But it probably won't hurt.
You and I were talking earlier today about induction and how if there is an issue with a cord that should be a reason to consider an earlier induction. And one of the questions that came in is about that as well. How can we convince our doctors to either do a C-section or an earlier induction but when there might be something wrong?
Well, if there's obvious cord problem, like entanglement, well, that one's not hard to figure out. Just put the baby on a monitor, and the minute he starts having D cells, deliver the baby. But we ran into that recently, and it doesn't matter if the baby's 36 weeks or 37 weeks. If he's having problems, that is more than enough justification for you to deliver the baby before 39 weeks. There's the 39-week recommendation is just that. It's a recommendation. Even if you want to call it a guideline, it's not a law. You're not breaking the law because you're inducing a baby before 39 weeks. So a lot of people will tell patients, well, the hospital will kick me out the hospital or I'll lose my license. All that's fiction. None of that's going to happen. The doctor-patient relationship is such that if you and your patient decide this is in your best interest, you have every legal right to pursue it and deliver the baby. And nobody has the right to interfere with that decision or tell you you can't do it. That's going to be onus on the people who are interfering. So what the moms need to understand is the 39-week rule is just that, a recommendation. It's not a law.
Okay. Let's see here. Let's talk about, so we had a question come in about the appearance of the umbilical cord. So a lot of people are told that, they don't know a cause. Is there something in the appearance of a cord that might indicate compression that doctors are just not looking for?
Well, in the cord itself, usually if there's been a compression site, like a knot, the cord is thinned at that site. But whether or not you can see that at ultrasound is another matter. I've never seen a paper that shows a thin segment like that or reported on it. But you can definitely see it once the baby's born. So I think a lot of these unknowns where they don't see anything, what can happen is you can have a hitch around an ankle and the ankle is compressing the cord against the side of the uterus. And when the baby's delivered, the loop gets pulled off the ankle so you don't see it. So nobody knows it was there. So a lot of these babies, what I've been trying to suggest are, they're called MRI autopsies. And they're doing it after the baby's born, where they're doing MRI scans of the baby. What I'm suggesting that they do is do the MRI before the baby's born on these stillborns that are mystery. And you might find some of these things like a loop along the side of the head, what they call a cult prolapse, or some of these mysteries. But it's very clear to me a lot of this stuff is broken up on delivery, and that's why we're not seeing it.
Yeah. We had several questions come in about, does X increase the chance of a cord accident? So I'm going to fill in a few of those for you here. So one that just came in the comments here is excessive amniotic fluid. Is that a contributing factor in cord accidents?
Yeah, that can contribute because the baby, it gets assistance in changing position. So yeah, it does.
Okay. Maternal age?
I'm not aware that maternal age is a factor.
Gestational age, does it happen at a certain time?
No, it can happen anywhere past 12 weeks. That's when the cord really starts to grow a lot. So it becomes long enough to get around something.
Okay. Single umbilical artery?
The single umbilical artery issue is in and of itself, a single umbilical artery is not dangerous. It becomes dangerous when it becomes entangled because it doesn't have a lot of structural support to prevent compression. So in a single umbilical artery circumstance, you got to look at it and make sure you're not seeing entanglement somewhere, because then that's when the baby's going to be at risk. So that's the confusion about that. There's 100 papers on single umbilical artery where they've tried to decide that, but they never did go back and look at the combinations. So there are combinations of details that can be a problem.
Okay. I think a lot of us found that we had one or two things that isolated would not have been an issue, but put together was kind of this imperfect storm.
Right. Another name for that's called complex UCAs, complex umbilical cord accidents. And again, that's something that we've written about a while back, that if you see several variables all put together, pay attention. Just don't think of just one thing. There was something on there about villamenous cord.
Yes. Villamenous or marginal cord insertions. Is that a risk? What kind of?
Yeah, it's definitely a risk. And not only that, what's important about that, these are cords that are attached to the edge of the placenta or into the membranes. What's important about that is that this is not uncommon in IVF patients. So people that are fertility patients need to have that looked at very carefully. They need to have those cords and placentas reviewed with ultrasound, looking for those marginal and villamenous insertions.
Mm-hmm.
There was something else there. I just saw another note about it, about villamenous.
It says, if you have it once, is there a chance of it recurring?
So far, I have not seen any suggestion that those things recur. The only thing I've seen is that the IVF patients are prone to having it because of the way they implant the embryo in the uterus. So it's very curious that they're predisposed.
Right. Are cord accidents more likely after 40 weeks?
Well, most of cord accidents actually happen between 35 and 38 weeks. So the 39-week rule is actually a bad idea for cord issues. And we did write an editorial to the Green Journal, American Journal of OBGYN, saying that, you know, this rule is a bad idea for cord entanglement babies because they don't die during labor. They die before labor. They die during the onset of labor, 35, 38 weeks. So that's a mistake. You know, what are you going to do if you see a baby that's entangled having D cells? You're going to tell the mama she can't have it delivered? I mean, how are you going to get around that? Well, the way you do it is you just say, to hell with the 39-week rule, you just deliver the baby.
Yeah. We had a question come in too about the mother's activity. So do things like having sex during pregnancy, can that cause any sort of cord issues, or being a very active
No,
mom?
because then everybody would have a cord issue.
Yeah.
No, it doesn't cause a problem.
Good. And I want to reiterate that too. I think as moms, we just often look at, if I hadn't done this, or if I had just not gone for the run that day, or, you know,
Oh, there's always questioning yourself. There's no doubt. But no, all this has to do with fetal reflexes, mostly during maternal sleep. And, you know, we've always contained talking about the fact that when you're sleeping, your blood pressure is lower than when you're awake. And depending on your physiology, depending on how you're put together, some of these babies may be reflexly maneuvering because your pressure is getting to a point where it's not perfusing the uterus as much. So the babies kick you and wake you up at night to make you change position. That's nature's way of dealing with that. But not everybody has 120/80 blood pressures. Some people have 90/60 blood pressures. And we used to think that that was a good thing, but you don't know what it is during sleep. It's like 80/55. And that's really probably not a good thing. So these people are probably waking up all night long because the babies are probably kicking them awake all night long because they're not getting enough blood flow.
Yeah. And I think maternal sleep is another very, very understudied piece of stillbirth for sure.
Yeah, well, I'm going to take the opportunity to say we're the first ones to make the association. We interviewed over 100 UCA lost moms, and they all kept telling us the same thing. This was published with the Royal College of OBGYN, and you know, we put it up saying, did you have movement before you went to sleep? Did you have movement when you woke up? And we found a lot of the babies with loss, when they woke up, didn't have movement. So that's what alerted us to something happening during maternal sleep, which brought in the concepts of low blood pressure and some other things. So we originally looked at that. No one had ever made that association before. And so what is needed next is they need, I'm trying to understand the question. The question popped up about blood pressure and cords around neck. They need sleep studies, you know, to figure out what's normal for maternal sleep. They don't have those kind of studies, even though there's I think his name is Strong out of Australia trying to figure that out. You know, what is the normal behavior of the baby during maternal sleep, under what conditions? And so we need to know what the norm is to figure out what the risk is.
Yeah. And I know there's some questions coming in about low blood pressure, and I mean, I think the idea with the blood pressure is just that it makes compression more possible. Is that right?
Yeah. More vulnerable. Yeah.
More vulnerable. Yeah.
Yeah. There are people that think in the research world that the cord has too much turgor pressure, hydrostatic pressure, that it can't be compressed, but it most certainly can. And they have people that have shown that in biomechanical papers that it most certainly can. So if your blood pressure drops and you're the baby, then you can certainly compress a knot or compress something because, you know, in essence, it causes you to faint. And so, you know, you don't have the same pressure when you faint, so your cord can be compressed. So it's more than doable.
What about PPROM? Is that a risk factor in a cord accident?
I'm not aware of a paper that said so.
Okay. And can you talk a bit about the relationship between placenta and cord? Is a small placenta a risk factor?
Well, the placenta, you want it to be a certain size, but I've certainly seen babies born where their placentas look like pancakes. I mean, there's a very small placenta, but they survive and they do okay. But yeah, there's a reasonable volume of placenta that goes along with normal pregnancies. So I don't know what that is, but people have looked at it. So in terms of weight, you know, you want placentas to be over 350 grams. I think 4 to 5 is normal. And then big placentas, like over 500 grams, those are usually associated with diabetic moms. So there is something to it, but you certainly can get by with a small placenta.
Is there a relation between small or placenta size and umbilical cord accidents that you know of?
No, not that I'm aware of, no.
Okay. What about doing an inversion for a breech baby?
Well, you want to look at the breech baby and make sure he doesn't have entanglement. You want to make sure that the cord isn't attached at the top of the uterus, what they call the fundus, because you don't want to turn the baby from a breech to a head down and essentially create traction on that baby. And so we recommend that if you're going to do it, you got to make sure the baby's not entangled first. And there is a case report that I have where the baby had 6 cords around the neck. So they decided not to do the breech version to create that tension. So that's a published case.
But they looked first. I don't know that they always do. Yeah. What about, I'm going to mispronounce this, but hyperemesis gravidarum, terrible morning sickness.
No, yeah, that one's mine. I've had hyperemesis with all of my children, and I just wonder, I mean, with the excessive vomiting, can that increase the likelihood that there's knots?
I don't know. I've never seen any study looking at that. You know, what is the incidence of cord problems in hyperemesis patients? So I don't know.
Yeah.
So you're going to fill out the pregnancy research project, Kathy, right?
Yes, I will.
Yeah. Good.
I will.
Let's see. A question just came in. Is there a relationship between cord compression and baby weight?
I've never seen a paper about that, but you would think that, you know, with a big 10-pound baby, there might be a connection.
I'm going to go back to, in the beginning, we were talking about how to talk to our providers about doing these scans that we're asking for. Can you tell everyone what you told me before this call when we were chatting in the waiting room there about the monoamniotic twins?
Well, the idea that we keep hearing from patients as they're being told that you cannot visualize the umbilical cord with ultrasound. And we're trying to teach the moms how to combat that idea, because in order for a maternal fetal medicine doctor to practice, he has to know how to look at umbilical cord in twins. Monoamniotic twins are babies in the same sac, and the most likely cause of death is a cord accident because they spin around each other. And so they most certainly must know how to look for it, because they can't do their job as a high-risk pregnancy if they didn't know how to do that.
So you can tell your doctors, if you can do this for monoamniotic twins, you can do it for my baby.
Exactly.
I'm going to ask another twin question. Is one compromised umbilical cord, which causes the death of one twin, automatically fatal for the second in a monochorionic diamniotic twin pregnancy?
Yeah, sometimes it is. I'm going to put this on the picture. I don't know if y'all can see this. Can you see that?
Yeah. Yep.
That's a monoamniotic twin cord entanglement that actually was sent to me the other day by Shauna Lipsack. Look how entangled it is. So if you're the maternal fetal medicine doctor, you got to look for that on ultrasound.
Wow.
Yeah, if you lose one twin, then there is a risk of losing the other one, and with that type of scenario. I'm going to put this up there too. This is the textbook. If y'all can see that, I'll turn it around.
No, that's good. Yeah, keep it there. Ultrasound, Atlas of Ultrasound in Obstetrics and Gynecology.
Yeah, so that's a 218 textbook printed by Harvard ultrasound professors. And if you look at the cover right there in the black, the blue and red, is a picture of an umbilical cord on the cover of the book. So.
Is that the Harvard one you mentioned earlier?
Yeah, that's the Harvard one right there. So, you know, that's the book that your doctor needs to buy if he says you can't see it, because it's right there on the cover. So you got to ask the question, does, you know, why did they put the picture of an umbilical cord on the cover of their book?
Nice, it's a nice image.
Yeah, so it inverted it.
Also, just so everybody knows, if you do need to show your doctor that this can be done, in the umbilical cord accident group on Facebook, which I think a lot of you are already part of, I did post pictures there of the scan that I had, and it's these beautiful cord photos in utero, and I just had no idea that could be done and that it was so simple. So.
Another source, if you go to Google ultrasound images of the umbilical cord, you'll see hundreds of them.
There you go. Exactly.
Those are the things you can print out and bring to your doctor and say, you mean you can't do this? And sometimes for their own education, they need to be, you know, shocked a little bit to say, you know, you need to know you can do this. How do you practice OB without knowing this?
We had a question come in from a mom who's had 2 losses, and I'm so sorry. She said that the first one was a placental abruption and the second was a nuchal cord, both very late in the pregnancy. Could there be a relationship between placental abruption and umbilical cord accidents?
Well, if there's tension on the cord, then that can connect to the abruption. It can pull the placenta free. And there was a question on seeing knots. So this is a recently published paper. There's 4 knots right there on 3D color ultrasound. So I'm showing you proof of ultrasound's ability to see a true knot right there.
And can you see torsion?
Yes.
Torsion in ultrasounds?
I'll get
Yes.
to that. Yes, you can.
Yes. Okay. This question, it's interesting. It specifically says, can a cord have torsion? Can torsion occur post-mortem? We've heard conflicting things, but I'll expand that to other issues as well. I think some people are told that things happened during the birth or after the birth, and so that wouldn't have contributed.
No, torsion does not happen after the fact. No. Torsion is the cause of death. That's the answer.
All right.
So where that comes from comes from veterinary medicine, because they lose a lot of racehorses to torsion, and there are people in the racehorse industry that don't want to think that's the cause because it reflects on them as veterinarians, and it really doesn't. Here's another image. There's torsion of the umbilical cord on ultrasound right there.
And that's a healthy torsion? Sorry, that's a healthy one there? That looks good?
Yeah, that one's an alive baby. But you can see where the cord, as it goes to the right, is going into the baby. But you can see the twists.
Mm-hmm.
Okay, and you can measure those twists. So it can be seen with ultrasound.
Okay.
So this is really nice to be able to get rid of those myths while I'm talking to everyone.
Yeah, guys, keep the questions coming. This is great. I'm glad that everyone's participating.
You can have a cord rupture is what it's called during delivery. That's what that question was about. You can have a weakened area for a variety of reasons and it'll just tear. Yeah, that does happen.
Good. Well, I think we're going to wrap up for the evening. I'm keeping an eye on things here, but we got through a lot of questions. And I've got, let me just check this list, make sure I got.
Well, I hope that helped everybody.
Let's see. Oh, got a few more coming in here.
Yeah.
We did talk about earlier if decelerations happen, just to have that constant monitoring until the baby comes out, essentially, once you see those decels, correct?
Right.
Yeah. And this one, if you have torsion, what do you do? Similar?
Yeah, similar protocol. Just keep monitoring the baby. If this information's helping y'all, shake y'all's head up and down. Okay, well, that's helpful. That's good to know. Okay.
And I see Crystal's asking, what's torsion called at the umbilicus?
There's two concepts. Torsion is twisting of the cord, and then you have cord constriction. Cord constriction is where the cord is narrowed at the belly button. So those are two different ideas, but they can be seen in the same baby. So sometimes they get confused with each other, but you have umbilical cord constriction, and that's a narrowing, and if it gets twisted, it gets cut off, and then you have torsion itself, which is general twisting of the cord.
Guys, I really encourage you, as questions do come up, Dr. Collins, I'm going to put you out there, but you've been such a wonderful resource for me and so many of these parents, and we just can't thank you enough for volunteering your time. There was a question that came up that said, do you have a practice in Louisiana?
Yeah.
And I so wish you still did.
Oh, well, not now. Whoever asked the question, no, I'll shut that down. But I'm more than happy to help anybody with the information. All they got to do is get in contact with me. Let Miss Laura know, and she'll put you in touch with me. And I'm just so pleased to be able to talk to so many of y'all tonight. That's been a great pleasure for me.